40 among your group. Okay, not to worry. So, we go to first question. Question number 1. Yeah. Anyway, this 20 question will cover 4 topics that I couldn't discuss during last group appointment. Anaphylactic shock, snake bite, pneumothorax, and at last, the patient with loss of consciousness. The first question here is, what is the first line drug in management of anaphylactic shock? Yeah, good. There was 100%, all of you gave a correct answer, that is IM adrenaline. So what is the point I wanted to highlight here? Any patient who presented with anaphylactic, there is no other drugs to give, that is only the IM adrenaline. Okay. Now guideline specifically mentioned that there is no place for clopidogrel, that is Piriton. There is no place for IV hydrocortisone. These are outdated practice. Guideline doesn't support. Right? But there are some exceptional situation where you might use clopidogrel and hydrocortisone. Okay. For example, if patient presented with predominantly urticaria, itching, you might use a non-sedative antihistamine such as cetirizine. Sometimes you can use clopidogrel. There is no much difference, but the guideline recommendation is you to use oral cetirizine. That is 10 milligram. You might use that and daily dose. We usually prescribe nocturnal dose. And if you happen to give hydrocortisone, why guideline does not support or does not recommend to use IV hydrocortisone is that all of us tend to give IV hydrocortisone at the beginning, even before use of IM adrenaline. That is why guideline does not recommend to use IV hydrocortisone. Because you know that IV hydrocortisone take at least 4 hours to act. So no point of giving during acute scenario. So if patient presented with like almost upper airway obstruction due to angioedema, yes, you might use IV hydrocortisone, but the action will not onset soon. Okay. So here the answer is IM adrenaline. Do you want to ask any question with regard to that question? No. Right. So we move to the second question. So where only 25% of you answer correctly. This is also best of 5 question. Question asks, what is the correct drug doses of following drugs in initial management of anaphylactic shock? So here, this kind of question can come in even your best of 5 questions. Okay, with the small stem, they can ask, because every intern house officer need to know the doses when it comes to the emergency, right? So here, the correct answer is first one. So you need to use IM adrenaline 0.5 milliliter or 0.5 milligram, 1 in 1,000. You need to correctly mention the doses, not the diluted one. That is 1 in 1,000. You just take ample and cut it, take it to syringe. It will have 1 milliliter. You can give 0.5 IM. So where you are going to give, that is lateral aspect of your thigh, nowhere else. Okay, use confident documentation where to give, what is the dose. And then next thing is you to start IV normal saline or 0.9% saline. What is the volume? So this is regarding an adult. The volume is you can use initial bolus of 500 to 1000 ml. Okay, and then you can give, if the saturation less than 94, you can give high flow oxygen. Never the anyway. So if patient come in with normal saturation, if patient has features of bronchospasm, better to give oxygen regardless of the saturation. So guidelines recommendation is you to give oxygen to keep saturation 94 to 98. But no one mentioned to wait until the saturation go down to 94. That is wrong. If patient present with anaphylactic shock, you got to start facial mask oxygen that you can start like 10 liters per minute. And make sure the saturation is 94 to 98. This is very important when the patient presented with respiratory symptoms. Right. So let's move one by one. Why the second one wrong? So IM adrenaline 1 milligram wrong. So you can repeat it every 5 minutes, 5 to 10 minutes by 0.5 ml or 0.5 milligram. That is why that is wrong. That answer is wrong. The next one is IM adrenaline 0.5, and then they have mentioned about the IV, the fluid bolus volume, 10 ml per kg. Nothing like that. Guidelines doesn't mention like that. The next one is IM adrenaline 0.5 with IV normal saline 1000. That is correct, but IV hydrocortisone, no. Hydrocortisone is not necessarily given for the anaphylactic shock. That is why it is wrong. So last question, a lot of people has answered the last one. That is IV IM adrenaline 0.5. That's correct. IV normal saline 1000, correct. Hydrocortisone 200, correct. Clopidogrel 10. So that is what you have seen in the word. That is why you remember it. Okay. So that is not the guideline recommendation. Guideline recommendation is the first one. When it comes to your question, the questions are made up of guideline basis. So they won't give marks for the last question. But it is debatable. Sometimes they might consider it, but guideline doesn't support the last steps. Okay. So 19%, 42% of you answered it as fifth one as correct. Any question regarding that? Question number 2. Okay, no. Right. Moving to question number 3. Yeah. If someone can share the questionnaire on screen, someone asking, if someone can share, it's better. So I can't share because I'm using my laptop. I'm logged with my phone. If someone can share a questionnaire on screen, that is better. Okay. So moving to question number 3. So what is the device? Yes, here 93% of you answered it as correct. So the device is EpiPen. So I know that this is come under anaphylactic shock. That is why you have answered it. But the thing is, it doesn't come that way when it comes to question exam. Okay, so you need to familiar what are the type of pen you have. If you work in ward and emergency department, you might have seen EpiPen preloaded one. What is the cost? Currently, it is 34,000. It's available. And the next insulin pen, all of you must have seen. And enoxaparin, you have seen. It is what is the color of the enoxaparin? Okay. And glucagon pen, again, is a kind of similar to this one. That is why I put it is in a box. In other countries, glucagon pen are provided to the patient to get injected if they have developed hypoglycemic episode at home. Okay, so it is again patient can keep it with patient at home. So EpiPen, yes, adrenaline inhaler. So adrenaline inhaler is not like that. So two of them you has mentioned it as insulin pen and one enoxaparin, 43. The rest of you mention it as EpiPen. All right. So moving to fourth question. 18-year-old male admitted with angioedema and stridor after taking seafood half an hour ago. So the blood pressure is 100/64. What is the correct order of management of this patient? So you need to mention correct order. So otherwise, so if you don't know what is the order, you won't get full marks, because in emergency you need to know exactly what is the treatment order. But we know that we will offer all the treatment at once, but at least you need to know which one to prioritize. Here correct answer is third one, IM adrenaline followed by oxygen, and then you need to nebulize with adrenaline and then give IV hydrocortisone. So that is the correct answer. So this is the exception. So here there is place for hydrocortisone because you have angioedema, right? So I know that when you are work at house officer, still you might use hydrocortisone and clopidogrel because that is the practice that was there for a decade. So I'm telling this is because I have recently requested to publish a case report of an anaphylactic shock which was encountered following spray of herbicide. That was later found to have sulfur containing herbicide. So that is very interesting case report. But you know that it was rejected because of we have used hydrocortisone and chlorpheniramine. So I mentioned it in case report because we can't find any information, and they mentioned that it is not updated management. Okay, so in other countries, that was International Emergency Medicine Journal. That was the other countries. They are not using hydrocortisone and chlorpheniramine. Right. So here you know that this is a seafood related anaphylaxis, but not the anaphylactic shock. Blood pressure is still normal. So patient is having significant angioedema. So this is important. This patient is an emergency. You need to manage correctly, though it is not anaphylactic shock, because next thing is the airway compression. So why first one is wrong? Because always in any anaphylactic condition, the management is IM adrenaline to begin with. So second one, why it is wrong? Because you need to remember next point. Actually, 22% of you have answered as second one correct, because why it is wrong is that it mentioned that nebulize with adrenaline, and you are not supposed to nebulize any anaphylactic shock patient present with angioedema and bronchospasm without oxygen. Okay, it will worsen your hypoxemia. At the time the alveoli bronchioles dilate, there will be relative hypoxia inside the alveoli, causing inadequate gas exchange. Therefore, you first give oxygen, high-flow oxygen, and then nebulize with adrenaline. So what we usually do is that we do nebulize through a oxygen supply nebulizer or oxygen supplying device. And here there is no you might use oral cetirizine, but answer is wrong because nebulize without oxygen. The first question, nebulize with adrenaline, no, you don't begin with nebulization, even though there is significant angioedema. First you give IM adrenaline. Next, last stem is 14% of you have answered. Last one is nebulized with adrenaline. No, you don't begin with adrenaline nebulization. Right. Okay. Any question with regard to fourth one?
So one question.
Yeah.
Sir, when we talk about giving oxygen, what's the best way to say, like high flow oxygen via face mask, or what? How to say it?
Yeah, high flow oxygen via face mask to keep saturation 94 to 98. When you mention that, you might further specify like high flow oxygen via face mask 15 liters. You can give 15 liters in this kind of situation. Okay? Because patient is having impending upper airway obstruction. You need to give maximum oxygen that you can give. So you might ask why we are not giving non-rebreathing mask oxygenation or high flow nasal oxygen. You don't need really to give high flow nasal oxygen in this situation. Giving high flow face mask oxygen is good enough. Right?
Okay, sir. Thank you.
Right. Okay. Even in the guideline, doesn't mention about the liters when it comes to the oxygen. They mention it as high flow oxygen. Right. Okay. Moving to the fifth one regarding refractory anaphylactic shock. So only 2% of you have answered that question. So that is worthwhile if I share the. So I will share to the group the answer given by you all with regard to that. Just see how the answers you have. You all. Right. Oh, here, regarding refractory anaphylaxis, what is refractory anaphylaxis is that if the anaphylactic shock is not improving after 3 doses of IM adrenaline, actually after 2 doses of IM adrenaline, so you will label it as refractory anaphylaxis. So what is the cause for that? They have hypothesized several things. Most common cause for refractory anaphylaxis is the inadequate dose or inadequate technique of drug use. That is the most common cause. Right? So that is most of the, even nowadays, we are not using adrenaline correctly. Most of the time we use subcutaneous adrenaline that doesn't have any place because of low blood pressure. There is no adequate supply to the subcutaneous tissue. Therefore, it won't relieve the symptoms. So you might not use correct dose. You might dilute it. So that is the most common cause for refractory anaphylactic shock. Anaphylaxis. So the next one is next possible thing is if you don't remove the positive organism or positive agent. For example, if you have some anaphylactic to some, for example, tick bite. Just imagine if you don't remove the tick, so it will be there even after giving adrenaline. How many adrenaline you give, it won't relieve. So if you don't remove the thing, it will be there. So for example, other thing is if you give drugs, regardless anaphylactic shock, right? So that is a cause of example of refractory anaphylaxis. The other one is, third one is that if you use repeatedly IM adrenaline for a long time, patient might develop tachyphylaxis. You know what is tachyphylaxis? When a receptor exposed to a adrenaline for repeatedly, it will cause downgrading of that receptor, resulting non-responsiveness. That is called tachyphylaxis. So that may be the last and least cause for anaphylactic shock. So the So what is the management of anaphylactic shock is that you need to start adrenaline infusion. Okay? So that is the management. So here the second answer is managed with noradrenaline infusion. That is wrong. So is there a place for noradrenaline infusion? Yes. You have start adrenaline, but yet patient is not responding. You might try it with the noradrenaline as a next option, right? But make sure you are not using other inotropes such as dobutamine and dopamine that can worsen the condition because of the venodilatory effect of the dobutamine and dopamine. The first line, if you happen to start infusion, is the adrenaline. The next thing is the noradrenaline. So correct answer was manage with glucagon if patient is on beta blocker. Yes, yes, very important, right? These days, most of the people are on beta blockers. If patient come with anaphylactic, you go through quickly drug chart, you found patient was on bisoprolol 2.5 BD. So you have given 2 cycle. Now you have given extra cycle as well. Adrenaline patient is not responding. So you need to remember this key point. If patient is on beta blocker, however you give adrenaline, the receptors are irreversibly bind with the beta blockers. So adrenaline cannot go and bind. So because of that, you need to give glucagon that has receptor stimulation action. It will help in this kind of patient. So most of you have answered it as managed with adrenaline infusion, 1 ml per kg per hour, 1 in 10,000 adrenaline. So the why it is wrong is 1 in 10,000. Because of that, it is not 1 in 10,000. You need to dilute it in to make it further dilution 1 in 10,000. Right? Okay. So any question regarding to that one? So remember, if patient is on beta blockers, you need to use glucagon. It is available in the same glucagon we use for the patient with hypoglycemia. You can use in this case. It is available in EDU. All right. So moving to the sixth one. What are the highly venomous snake in Sri Lanka? So I have shown a picture. Okay, it's important. Can you identify snakes? What is the correct answer here? Only 2% of you, only one person has answered correctly. What is the correct? Okay. First one, who is first one? First one is
Zooskill Bibles.
first one. No. Is that?
Yes, sir.
No.
Vital.
What is that? Okay. Second one, B.
Sri Lankan crates.
Okay, Ceylon crate. Okay, right. C.
Hub-nosed viper.
Yeah, that's correct. D.
It's a cat snake, sir.
Yeah, D is a cat. Yes. Here, A is a, you are correct. This is a saw snake so scale snake, and B and C, and the B is the Ceylon crate, C is the Humphnose viper, and then the D is the cat snake. So why C was mentioned like this? If you think about the circumstance, so this patient is under grass, a wet place, so appearance is also Humphnose. Okay. Cat snake you need to identify as a spot, and cat snake doesn't take as a venomous, highly venomous snake in Sri Lanka. You have only 6 highly venomous snakes. I have mentioned it in in explanation. Have I given an explanation? No, ne? Anna, I have given explanation. There are 6 highly venomous snakes in Sri Lanka. So that is cobra, common crate, Sri Lankan crate or Ceylon crate, Russell viper, Humphnose pit viper, and there are 2 types of Humphnose vipers. So here when you answer, so A is correct, but it is not given in the question, sorry, as an option. So B and C, you need to take both as highly venomous. So that is why B and C is correct. Be careful when you answer. So if some answer was there as A, B, and C, that is the correct. But here among these, you need to choose B and C as correct. Any question?
So why A is not considered as highly venomous?
No, that's what I meant. A is correct, but it is not given as an option. So that is kind of this activity, not just purely discuss with you emergency, this part of it. What I wanted to know is I wanted to show is that. So this is kind of exam question come to your exam. So you need to answer within 30 minutes. So you need to choose a correct answer. So here there is no other option. If you mention it as only A, definitely wrong, right? Only B, definitely wrong. All 4, definitely wrong. B, C, D, because of D, wrong. B and C, that is the only option you have.
Okay, sir. Thank you.
Yeah, sometimes answers come like that. Be careful. You read every question. Most of the time they won't trick you. Here also they haven't tricked you. But careful. Read the rest of the answers. Okay. Read the rest of the answer. Today activity you got only 30 minutes, limited time, and it was scheduled to be start at correct time. So exam come like that. Even though it is not online paper, exam come like that. So you need to prepare. You need to read. And you need to go through all the 5 steps. Okay. Right. Don't hurry and answer. Right. Anybody have question? If no, we'll move to the next one. Snake bite happen in damp place around dwelling, sheds, garden, under the leaf, bites on limb, extremity suggestive of. These are called circumstance evidence. So you need to know these circumstance evidence to, if the victim doesn't come out with the dead snake, or if victim doesn't give good account of the features of the snake. So you have to use circumstance evidence to find the what is the culprit. So here is, this is explanation is that the snake was in a wet place under the leaf. So bitten in the extremities. So under the leaf, what are the possibilities? The possibilities are, the first come is the Humphnose. Okay. So scale wrong. They stay in the sand containing area, under the sand. So that is because of that, so snake scale viper is wrong. The crate is not the circumstance. Crate bite happen in the night while sleeping on the floor. Okay. So cobra also comes in the cobra bite also in the peripheries, extremities, but it doesn't hide inside the shade under the leaf. Okay, unless it is small cobra. Most of the time, the bite happen when you people who work in the paddy field and where like they try to remove this grass and when they try to harvest the paddy, cobra bite happen. So Russell viper bite also like that. So circumstance evidence are here suggestive of hump-nosed viper. Okay. Yeah. Yes. Most of you have answered it correct. Any question? Okay. Moving to the 8th one. Following are each of systemic envenoming except. Yes. Very important. Most of you have answered correctly. What are the systemic envenomation features? They will take only 2. One is neurological features. Other one is coagulopathy. Okay. Only these 2 considered as systemic envenoming features. The other one is the local envenoming features. Okay, right. So moving to next one. It's a very easy question. Next one, snake causing neurotoxicity in correct order. So this is again important because patient sometimes doesn't produce the features of the snake that bitten the patient. So you need to find out based on the clinical features what is the possible snake. For that you need to know who cause most the neurological feature. So here, as you all know, the crate need to come first. So all 5 answer contain crate as first. So next 2 is the important. Russell viper doesn't cause much neuro features, right? It causes most of the time coagulopathy, but it can cause neurological features. Okay. So 60% of you have answered it correctly. The correct answer is the second one. The crate is the highest neurological feature, then cobra, then the Russell viper. That is the order. Hump-nosed viper doesn't cause a neurological feature, but the local feature, venoming features, as well as sometimes it causes AKI, venom-induced AKI. And the sword-tail viper most of the time cause coagulopathy and AKI, but doesn't cause neurological feature. Crate, Russell viper, and sea snake doesn't cause neurological features, but it can cause severe muscle toxicity and so muscle damage and myoglobinuria, and then the renal involvement. Therefore, it is also wrong. So the correct answer is crate, cobra, and Russell in that order. Right? Is it clear? Okay. We'll move to the next one. 10th. What is true false regarding whole blood clotting time or WBCT 20 in case of snake bite? So you need to know very correctly what is the indication, how to do it. Why? Because you are the one, intern house officer, the one who manage snake bite patient when it go to the peripheries. Okay, not all hospital has registrars, not all hospital has SRs. So you and consultant along need to manage. Most of the time you cannot reach consultant. In between there will be SHO supporting you, but you need to know how to do it correctly. Okay. So whole blood clotting time 20 minutes has low sensitivity for detecting coagulopathy in snake. Yes, that is correct. By the way, this kind of question is not exactly similar to true false question when you score it, because it doesn't, if you answer at least one wrong, it will give 0. Okay, this Google form is made up like that. It doesn't count like if you answer one correct, they will give 1/5 of mark. No, it doesn't come like that. Okay, so that is why most of you got a little low marks, but I can't change it. So first one is correct. So it has low sensitivity for detecting coagulopathy. It is mentioned that way in guideline. Okay, only 22% of you made it correct. Okay, even though you do it, it doesn't 100% sensitive. So for what you need to do is that always you need to take the clinical features in combination with the WBCT time. If patient is having bleeding, why do you need to wait until the WBC become positive? Okay, you might need to treat it. Okay, you need to treat it. No, you need to treat it. Okay, if patient is having mucosal bleeding or bleeding somewhere, but WBCT can cause positive, cause negative, right? Okay, wet glass tube can cause false positive result. Yes. So if you go and see the down, I have mentioned the other condition that can cause false positive result. If you don't use silica tube, so glass tube, if you use plastic tube, it can cause positive. Okay, so you need to use the glass tube, and you should not make it wet. Okay, you need to use dry glass tube, and you should not add any other chemical inside it. You should not clean that glass tube with detergent or soap. Okay, it can cause false positive results. Right? It is a bedside test. Yes. Okay, 98% of you have answered that correct. Right. So no place for PT-INR, no. So you need to do PT-INR and APTT as an adjuvant for the WBCT time, because even WBCT negative, if others positive, you need to treat it. If test is positive, you need to repeat. No, why you need to repeat it? Unless you have doubt that it is false positive. Okay. So what I mean, so if patient present with dead snake of a viper bite and patient has nasal bleeding, if it is positive, it is positive, you treat it. Okay. If patient present with not sure, you are not sure whether it is venomous snake, you did the WBCT, it is positive, patient is fine, doing well. You are in doubt. In that case, you can repeat it and see. Okay? Not always you need to repeat it, but if you have doubt only, you need to repeat it and see. Okay? Right. So use correct method and you don't need to repeat. Any question with regard to question number 10? Okay. So we'll move to the next one. Regarding antivenom. Yeah, the first one is correct. We use polyvalent antivenom in Sri Lanka, so Indian made one. Effective against Hamnoff, no point of using for Hamnoff viper. No place for antivenom in patient present up to. No, that is very important to remember. It doesn't, you don't need to count the time at which time patient has encountered with the snake. Okay, at any point you see the patient, if patient has features of systemic envenomation or local envenomation of, in case of cobra bite, you need to give antivenom. Okay, right. Around 80% of patients who received antivenom will develop reaction. Yes. Among them, around 40% will develop anaphylactic shock. Why I mention it in here? Because that you need to know. If you don't expect it, you won't prepare for it. So 80% of people will develop some sort of reaction that warrant you to stop it temporarily and give adrenaline and sometimes antihistamine. Okay, right. Premeditation with antihistamine and hydrocortisone is needed. No, it's wrong, because premeditation with adrenaline, only for adrenaline there is place, not for antihistamine, not for hydrocortisone. Again, here they discourage to use antihistamine and hydrocortisone, but they encourage you to use subcutaneous adrenaline as premeditation in case of antivenom administration. Before administration of antivenom for each and every patient, you got to give subcut premeditation for premeditation subcut adrenaline. Okay, that is 0.25 ml of 1 in 10,000 adrenaline. Any question? Okay, let's move to the next one. Question number 12. True or false regarding antivenom administration. Again here, need to use low dose in children. No, important point. It doesn't. Antivenom is a kind of, just imagine like this, antivenom is an antidote. So antidote need to be given according to the venom amount present in the body, not according to the body weight. If you have only two venom inside the body, you need to go 2 antivenom. If you have 10 venom inside your body, you need to go 10 antivenom. If you have 1,000 antivenom, 1,000 venom inside your body, you need to go 1,000 antivenom, regardless of your age, body weight, or whatsoever. Right? All right. So in adult, need to be diluted to total volume of 500. Yes. So you take. So usually antivenom comes in as a vial, so ample, that contain 10 ml. Usual dose is you start with 10 ample. You take 10 ample, that is 100 ml, and you need to take normal saline, 500 ml normal saline 1 pint, and remove 100 ml of normal saline from that, and you add that 100 ml of antivenom to that in a premeditate patient and give antivenom via IP as a 1 hour infusion, while connecting to the cardiac monitor and monitoring pulse rate, blood pressure, saturation. Right. And your emergency trolley need to be prepared. You need to draw adrenaline beforehand, right? Because 80% will develop reaction. Right. In cobra and crate bite, usually 1 antivenom dose enough. Yes. Cobra and crate bite, you don't need to repeat it. 10 ml, 10 ample would be enough. But when it comes to Russell Viper, you know that Russell Viper causes most of the coagulation abnormalities. So you know that Russell Viper has this tank that is enclosed. So most of the venom going inside to the body after bite. Okay. So in that case, the antivenom dose need to be high dose. You need to use. You start most of the time with the 30 amper. Okay. Right. Persistent neurotoxicity is an indication to repeat antivenom. No, neurotoxicity, you don't need to repeat it. Only for the coagulopathy, you are going to repeat the antivenom. Only for the coagulopathy. That means only after repeating WBCT at 6 hours after giving antivenom, you will consider to repeat antivenom of 10 amper. Okay. So simply, if patient come in with crate or cobra bite, you give 10 ample and leave it behind. If patient come with viper bite, you give 30 ample and then you need to repeat WBCT in 6 hours. And if it is positive, you need to give another 10 and again repeat in 6 hours and see until WBCT time negative, you need to give it. Is it clear? Okay. Is that part clear? How to give antivenom important, right? You need to premeditate with 0.25 ml of 1 in 10,000 adrenaline. And then I have mentioned how to prepare the antivenom and over 1 hour you need to give and how to monitor, right? Let's move to the next question. Right. Question number 13. True false regarding management of reaction to antivenom. Again, very important. So early anaphylactic reaction usually occur within minute up to 180 years. There are 3 types of reaction can occur. So one is early anaphylactic reaction that occur within like 2 minutes, several minutes to the up to like 180 minutes. Okay, early phase. The next come is the kind of anaphylactoid-like reaction due to endotoxin and not anaphylactoid. It doesn't mean name as an anaphylactoid. It is like due to endotoxin mediated reaction that occur 1 to 2 hours after. Okay, and the late thing is because of this antivenom, they can develop serum sickness-like syndrome. Usually, at on 7 days of after giving antivenom. Okay, so you mentioned it as 5 to 10 days after giving antivenom, they can develop late reaction that is called serum sickness syndrome. Right. So here, yeah, antihistamine and corticosteroid no longer recommend. Yes, it is not recommended for anaphylaxis in long. Okay. Third one is strong chills, strigo, fever, vasodilatation with low blood pressure. Here, if you see carefully, these are patient is having features of like fever, chills, strigos are not a common features of anaphylaxis, right? They don't develop fever, chills, strigo. They will develop urticaria, itching, angioedema, respiratory symptoms rather. These are the features of endotoxin mediated reaction that comes 1 to 2 hours after giving your your antivenom. You know, antivenoms are made up of you give venom to a horse and then you take sera of that horse. So horse sera has lot of other endotoxin protein that is foreign to human body. When this endotoxin come to our body, we develop a febrile reaction. So that is can come with even low blood pressure. So that is not anaphylactic shock. I'm repeating it. Patient can come with febrile pyretic reaction with vasodilation and the low blood pressure. It is not always anaphylactic shock. It can be due to endotoxin that is present in the serum. So it usually comes little late than the anaphylactic shock. Anaphylactic shock usually comes within second. Early anaphylactic reaction come within like minute after giving, and even it can present 180 minutes after. Yes, I agree. But here endotoxin mediated reaction usually occur after like 60 minutes after giving the antivenom, right? Okay. IM adrenaline is not recommended if patient present coagulopathy, no, that is not mentioned in this case. In other situation, if patient has bleeding tendency, we don't give IM drugs, but this is life-threatening condition, anaphylactic shock, life-threatening condition, that we have treatment option, that is IM adrenaline. So we don't consider here hematoma formation as significant thing when we compare to the life-threatening anaphylactic shock. So first you give IM adrenaline and recover patient from anaphylactic shock. Most of the time they won't develop hematoma. If patient develop hematoma, you can't help. Right? Okay. Next thing is antivenom should not be given anymore if patient develop anaphylactic reaction. No, wrong. What you need to do is if patient develop anaphylactic reaction or endotoxin mediated reaction. So these are the conditions you need to consider regarding continuation or discontinuation of antivenom. You are not supposed to stop antivenom because that is the life-saving treatment. Okay, you don't discontinue it. You stop it temporarily. You stop it and you give IM adrenaline and wait for like 10 to 20 minutes and restart it. Okay, you restart. If patient develop again urticaria, okay, stop it. Give IM adrenaline, restart it. So this is the condition kind of refractory anaphylactic shock because you have to continue the injurious agent. Is it clear? Right. If you have question, you can ask. You can disturb me and ask. Okay. We'll move to the 14. Because of the time factor, I'm moving a little fast now. 16 years old, previously well school boy presented with sudden onset SOB following a bout of cough while trying to get into the bus. Pulse rate 110, blood pressure is little low. His chest X-ray show below. What is the likely diagnosis? This is, you know that. Here, so there is again, when you go through the answers, you need to be careful. There is 2 similar answers. When it comes to best of 5, this is like that. There will be 2 similar answers. That is how the questions are made. And that is how scrutiny board decide to decide on the answers. Okay. So here, right side pneumothorax is obvious. Yeah, that is why 46% of you have answered that is correct. But the correct answer is tension pneumothorax because there is tachycardia and there is low blood pressure, marginally low blood pressure. If you carefully see the chest X-ray, there is mediastinal shifting. You can see the trachea is little curved towards the left side. Okay, in middle part, trachea is little curved towards the left side. And not only that, you can see that there is no crowding of rib. So that is why lung collapse is strong. There is no crowding. If it is lung collapse, there will be crowding of rib. Okay, right side, the primary pneumothorax, you can't say when there is better answer. Here, actually, right side pneumothorax answer is correct. Tension pneumothorax is correct. Primary pneumothorax also correct. But among them, best answer is tension pneumothorax because of low blood pressure and mediastinal shift features. Why it is primary pneumothorax? Because this patient doesn't come out with previous history of any lung disease. Young patient. This is the common presentation. So this question is deliberately made you to get used to what is the common presentation of primary pneumothorax. They will come with, they will try to catch a bus. They will play badminton. They will play and they come with sudden chest pain. My right side, left side chest pain and following cough. They develop bout of cough. They will cough once or twice. Sometimes it won't be there all the time, but they will develop sudden chest pain and SOB. Pneumothorax is very important to explore because otherwise you will manage it as MI and patient will die because you haven't done the emergency decompression. Be careful. I have seen one patient during first 3 months of SR period here. They have missed the diagnosis. Okay. If you don't suspect, you will miss the diagnosis. So if you miss the diagnosis in the night, you will miss the patient in the morning. Patient will die. Okay, right. So what is the immediate definitive management? Immediate definitive management. I don't care whether you give oxygen or not. No place for noradrenaline here. So emergency IC tube insertion, you don't wait until you insert the IC tube. 32% of you have correct mentioned it as correct. No, because IC tube insertion will take in our setup at least 3 hours, even it is how emergency. So you don't wait until that. You do the emergency needle thoracotomy. All of you need to know how to put it. Okay, you are, even HO can do it. You percuss and you confirm there is pneumothorax and check the trachea. Trachea is deviated. You don't need to wait on the chest. For the chest check. No. Okay, what is the maximum cost that you can do? Is you can punch a normal lung. Okay, what is the treatment? You take chest X-ray, and if you have punched a normal lung, sometime there will be pneumothorax. So maximum thing is you put IC tube and keep for a couple of days, and this your punch will nicely healed. It will cover with the visceral pleura. Okay, right. Right. Intubation, there is no place. So 16th one, what are the indications for IC tube in pneumothorax? Yes, there are 4 correct answers here. Tension pneumothorax, bilateral pneumothorax, failure to needle aspiration, and traumatic pneumothorax. There are indications for IC tube insertion. If it is primary pneumothorax, if it is more than 2 centimeter, you need to do needle aspiration. Not to, you don't need immediately go and do the IC tube. But when it comes to second pneumothorax, yes, if it is more than 2 centimeter, you need to go for IC tube. No doubt. If it is primary pneumothorax, first pneumothorax, if it is first presentation, if you think this is primary pneumothorax, no other lung pathologies, so you don't need to go for IC tube. You do aspiration. If you fail or if it reappear, then consider IC tube insertion. Next one. What this patient underwent IC tube insertion, and I have mentioned the picture. What is that picture? So anybody? Yeah, you have correctly answered that. So this is kind of, you can see there is facial swelling and periorbital swelling. If patient you put IC tube and patient develop like this, I have observed this during my HO period in surgical ward. So patient can suddenly develop like this. How many days will it take? No, it won't take days. It will only take a couple of hours. Patient will come like this. Okay. So what you need to do is you need to readjust the IC tube. This is due to surgical emphysema. So air leak happen. If you do not put all the ice inside ice of this IC tube inside the rib cage, and air can leak to subcutaneous plane, and it will go up and up and surrounding the neck and to the face. So what is the risk is that when you introduce air to the surrounding neck and the chest wall, you can create some sort of pressure at that point, and it will compromise your breathing for a certain degree. Okay, so you don't need to do extra thing. You just put ice inside, and if patient has airway compromisation due to this the pressure at neck, you might need to go for non-invasive ventilation. Next question. Yeah, 54-year-old previously well patient was found unconscious at his apartment. On admission, he was hemodynamically stable. ECS 8 out of 15. You have assessed the patient and start on oxygen. What is the next step of management? So this is related to the loss of consciousness patient management. What's the next step is that, so you have done basically A, B, at least A and B, and you have started on oxygen. What is the next option, next step of management? So it doesn't mention in answers regarding blood pressure or something related to that. Okay. So next thing is you need to decide where is the problem, whether it is intracranial problem or the extracranial problem. So you need to identify the cause for loss of consciousness. You don't have time to act. You don't have time to wait. You need to have hunger for the cause of the loss of consciousness. The patient doesn't come with loss of consciousness without reason. No? You need to find it. So how to enter? You need to first decide whether it is inside the head, outside the head. My head in the sense inside the skull or the outside the skull. There is important clue if you do assess disability. Disability in the sense you check the pupils that will provide you most important valuable piece of information when it comes to a patient with loss of consciousness. Okay, very important. So you assess the pupils. If the pupil, what you are going to see, whether pupils are normal size. If both pupils are normal size, intracranial pathology is unlikely. Because to cause loss of consciousness, if it is large hematoma, it will definitely cause pupillary changes. Small hematoma doesn't cause loss of consciousness. Small mass lesion doesn't cause loss of consciousness. To cause loss of consciousness, it should be large enough to cause pupillary changes. I think you got my point. Okay. So if it is MCA infarction, sometimes there won't be pupillary changes, but there will be slow reaction to the pupil response. See? And there might be some asymmetry if patient has significant cerebral edema. That is the cause for loss of consciousness. MCA infarction alone doesn't cause loss of consciousness. No? Because of the edema only, they will cause reduced consciousness level. Okay. So it will cause pupillary discrepancy and reaction will be low. If both pupils are constricted, again, there is no intracranial pathology. I will describe later why it is not intracranial. Right. So next thing is to do the pupillary examination. Intubate, no. Why you need to intubate this patient who has GCS 8? The guideline mention if the GCS less than 8, okay, you need to intubate the patient. Provide. You don't start oxygen if you want to intubate. No, that is again a clue. You have assessed the patient and start on oxygen. You are telling that if you answer like intubate, that is 56% of you have answered that intubation is the correct answer. That is that you fool. You don't know this patient needs intubation. The STEM is telling that this patient doesn't need intubation. That is why STEM has started on oxygen. But you are telling that, no, you fool, this patient needs oxygen. It doesn't tally, right? So when you're going to find answer, you just think that line as well. There will be clue that will help you to exclude that answer as a correct answer. Right? Okay. So always low GCS like 8 marginal GCS, you don't embark and do intubation because we have seen people who is with OP poisoning, opioid poisoning. They have intubated when the GCS around 8, and after like naloxone, patient run with the tube. Okay, you just check the pupils. If both pupils constricted, so most likely patient has taken heroin or some sort of opioid. What you need to do is naloxone. Then patient will jump out of bed and run. So if you intubate without checking pupils, so that is why I included this question. Okay, moving to the next one. Any question with regard to that? No. Let's move to the last 2 questions. 26-year-old boy admitted to ETO with altered level of consciousness. On examination, he is drowsy and GCS 11 out of 15 pupils, 6 milliliter bilaterally, reactive and tachycardic, blood pressure little high, excessive setting. What is the toxidromes? Yeah, most of you have find it as the correct one. So 40% you have 40% of you have find it as correct. So that is sympathomimic. You know, you need to remember this at least 4 toxidromes. That will help you to find what is the cause for this altered level of consciousness. Toxidromes are the set of a collection of signs and symptoms that patient has. Based on these collective symptoms and signs, you can decide which type of injurious agent, which type of drugs, which type of toxin patient has taken. Then by guessing that, you can start antidote, or that directed therapy you can start. Here, all the features are, you know, you will have dilated pupils when you in a flight or fight reaction, right? You will have dilated pupils, your pulse rate will go up, heart rate will go up, your blood pressure will go up, you will sweat. So that is sympathy, sympathomimic or adrenergic toxidrome. The correct answer is 3. Right? Okay. Because of the time, I will share what other toxidrome, and I'm not going to discuss here. You need to have a chart. What are the features of toxidrome? It's very important when you practice day-to-day life. Okay. Okay. So next, what is the possible positive agent in this case? Okay. If you don't know what is the toxidrome, you can't find the positive agent. Here, this is sympathomimic toxidrome. The answer is methamphetamine. Methamphetamine. Okay. So why it is different from opioid? You know that when you consider this age, this presentation will be very common when it comes to next couple of years, because now everywhere methamphetamine is available. So, everywhere. Okay. If you go and then if you are going to street, you meet 3 people, 5 people, at least 2 of them on methamphetamine. So you need to know you need to be thorough with the methamphetamine features and how to manage and what are the things you need to do and everything you need to know. Right. Okay. Any question you need to ask at this point? So I took 15 minutes extra time. Any question? Anyone? Okay. So no question. Let me tell who has got maximum answers. Okay, right. So maximum answers I will strict up to the time limit, that is 7:30. So I'm not going to mention the name. So I will mention the scores. The first winner is 80 out of 100. Can I mention the name? You know, right? It doesn't. That is JA0. I don't know who is that. The second one is 75 marks. That is PR3. I don't know who is PR3. So if I combine to 30 minutes, the third one is CK5. That is 65 marks. Okay. Right. So you will receive your prizes in future. And the people who got more than 50 or 50, JJ2, BA1, SK5, UE0, EB3, and SDS8. And someone like 659 and 603. Yeah, up to the given time, that's all. You might get low marks because that true false question was not correctly marked here. Okay, anyway, so we don't need to waste time anymore. We'll stop here. If you have any question, you can even share to our group.